We are live.
Good afternoon, everyone. Welcome back to an exciting session for the AIOS International Ophthalmic Conclave, the fifth one taking place today on 26 January 2025. Happy Republic Day to all of you. The session right now will be Goal 2020 Towards Perfection in Refractive Surgery, a very pertinent topic for all of us. The moderator for the session will be Dr. Rupal Shah. The chairpersons are Dr. Ramamurthy, Dr. Zhao Singh Tao, and the panelists for the sessions will be Dr. Pooja Khamar and Dr. Ruchaita Ranti. I'll be your session coordinator for the session, Dr. Arshi Singh. Thank you for being here. I request Dr. Rupal ma'am to please start the session.
Thank you, Dr. Arshi. Can I share my screen now?
Yes, please.
So my screen is seen now?
No. Ma'am, we can see the screen, but not the PPT. Yeah, please. Thank you.
So we have today's topic is about Goal 2020. So we have the best faculty here to achieve that goal for 2020. And I'm very happy to introduce the first faculty member. Excuse me. I think there is some glitch here. Somehow it's showing only one slide.
Ma'am, you're okay. The slide is showing. You can just
Yeah,
go.
but it's not forwarding. So
there's only one slide on this presentation.
yeah, so that is that's not the one that I have to. Just give me 1 minute. Dr. Ramamurthy, can you please go ahead and introduce the topic? I will just sort this out.
A very good morning, good afternoon, and good evening, ladies and gentlemen. Thank you so much for joining us. And this is a refractive surgery session of the International Ophthalmic Conclave, a prestigious event of All India Ophthalmic Society. And thank you all for joining us. And Goal 2020 is obviously the what we are all aiming at, whether it's cataract surgery or refractive surgery. And as refractive surgeons of third millennium, we owe it to ourselves and our patients. And whatever be the kind of a problem that they presented to us with, for a long time, refractive surgery was a single procedure specialty, PRK in 1980s, 1990s, 80s it was RK, PRK in 1990s, 2000 it was all LASIK. Now we have multiple different options. All those remain. We added on to that is a flex procedure, intracorneal ring segments, intracorneal inlays. Then we have the phakic intraocular lenses, lens exchange, etc. Obviously, we have a basket of choices, but that also places a onus on us to give the very best to our patients each day in and out. And to take us through these different procedures, give an update on what's current, we have a renowned faculty from the entire Asia Pacific region. I'm truly looking forward to this event, and I think there'll be a lot of interaction, lots to learn from this wonderful session. Over to you, Dr. Rupal, our moderator, who herself is a very acclaimed, very internationally renowned refractive surgeon, was one of the pioneers as far as SMILE is concerned, but involved in all types of refractive surgery. Over to you, Dr. Rupal.
I think I have the correct PowerPoint now. So I'll share my screen. So Dr. Ramamurthy does not require any introduction. So I'm not really going to try. It's like showing a lamp to a sun. So I'm really not going to try that. So I jump to the next eminent ophthalmologist of the world, Professor Zheng Tao Zhao, a very dear friend, president of Eye and ENT Hospital, Fudan University, China. He has 100 surgeries today, and yet he is here to be with us. He's a director of the Ophthalmology Quality Control and National Health Commission, China, director of Shanghai Research Center of Ophthalmology and Optometry, China, president of the Yangtze River Delta Ophthalmology Diagnosis, most excellent doctor by Publicity Department of the Central Commission of the CPC and National Health Commission, and so on and so forth. I actually, if I talk about Professor Zhao, it can take the whole session. In fact, each of the people who are present here today deserves to be talked about for hours together. The next one is Dr. Pooja Kamar, who is also a panelist in this session. She's a consultant in cataract, dry eyes, and refractive services at Narayan Netralaya Eye Institute, Bangalore, and was instrumental in having the second edition of the Lenticule Congress just recently, last week. And it was a beautiful congress which was totally dedicated to lenticule extraction procedures. She is a distinguished as one of the few surgeons globally with expertise in all laser-based platforms for refractive surgery. And she very well demonstrated on at least 2 platforms in that surgery, in that meeting. And she's the recipient of the Troutman Award, acknowledging her significant contribution to research. The third eminent ophthalmologist is from Java, Indonesia. She is Dr. Ruchaita Ranti. She's head of iLink Education Program. She's a medical staff in KMU Eye Clinic and National Eye Center, Surabaya, is Java, Indonesia. And I have I have a pleasure to know her since many years, because she has also been the LASIK and SMILE instructor at National Eye Center, NEC Surabaya, where I have also been called many times as faculty. Dr. Rolika Bansal is the research fellow UC San Diego Shiley Eye Institute. She is an eminent oculoplastic surgeon of the world. Dr. Somshela Murthy, founding medical director of the Shantilal Shangvi Eye Hospital, Mumbai. She's been with the LVP from a lot many years. She's a member of the Scientific Committee, All India Ophthalmological Society. And she's headed the cornea service at Hyderabad campus from 2012 to 2023, a very well accomplished and a dear friend. She's been busy with another meeting right now. So her talk, Dr. Manik Nicholson is going to give. She is also a consultant at Shantilal Sangvi Eye Hospital and a fellow of NN. Dr. Syed Maz is the consultant and Center for Sight Hyderabad, doing refractive surgery since 18 long years. He looks too young and his looks are really deceptive. He's a recipient of the Intraocular Implant and Refractive Society of India Gold Medal and has delivered C.S. Rashmi Endowment lead. So he's a very young, dynamic, and a very well-experienced cataract and refractive surgeon, and his words of wisdom will be able to hear today. We also have Dr. Mazin Sinjab, a professor of ophthalmology and consultant ophthalmic surgeon at Dr. Suleiman Hospital, Dubai Healthcare City. He is the founder and secretary general of International Keratoconus Society, and he is very well regarded all across the world as ophthalmic teacher. He has sent his recording, so I'll be able to play it for you because he also could not join us. Dr. Patrick Versace, a dear friend and a person whom I have admired and respected for years. He has cataract and refractive surgery experience for more than 25 years now. And he's an early adopter of LASIK in Australia. He has been deeply involved in the development of laser technology for vision correction surgeries. Very warm welcome to you, Dr. Patrick. Dr. Karitsan is another very dear friend. We've done a lot of conducting of symposiums together. and he is the most witty person I know. He is an associate professor, international in Islamic University of Malaysia, director of cornea external service and refractive surgery services at Quentin. And he has published a number of articles in scientific journals and made over 300 other scientific presentations. And we have a very young, dynamic fellow, Dr. Raghav Malik, with us, who is an associate consultant at Center for Sight. He's a trainer in phacoemulsification and refractive surgery, already has multiple publications in index journals, published results, first results in the world of silk, and he had this opportunity to study silk. And for the first few patients were treated under, along with his guidance. Dr. Gitanshu Sachdev, a senior consultant, cataract and refractive surgery, the Eye Foundation, Coimbatore. She is one of the youngest recipient of Intraocular Implant and Refractive Society of India gold medal for her achievements in cataract and refractive surgery. And I'm not surprised at that. She has the genes and the environment, and both she has really imbibed, and with her hard work has achieved something that most young people aspire for. She's an assistant editor of refractive surgery for Indian Journal of Ophthalmology from 2017 to 22, and already has numerous publications and peer-reviewed journal articles in peer-reviewed journals. And that gets us to Dr. Osama Ibrahim, again, a very dear friend, an old friend, an early adapter of SMILE procedure. We've done so many studies together, and I've learned a lot about not just ophthalmology, but also life from this great person, an immediate past president of Alexandra University and distinguished professor of ophthalmology. Dr. Ibrahim has promoted refractive surgery all over the Arab world and Middle East, and he's the recipient of the Miyako Distinction Award and the AAO Lifetime Achievement Award. A warm welcome to you, Dr. Osama. So that gets us to the main program, and I think we can go ahead with the first talk, and that is on surface ablation. And this would be delivered by Dr. Nicholson. Dr. Nicholson, please go ahead.
Yeah, thank you so much, Dr. Rupal. Are the slides visible?
Yes, they are.
Okay, so thank you so much for giving me this opportunity. It was actually Dr. Somshila's talk, but I'm glad to fill in for her. So I'll just take you all through a brief overview of the complications which we see in surface ablation, which is PRK surgery. So I thought I'd start off with just a simple video to show what the surgery is like. It's quite a simple procedure. Here, an oil scrubber is used to remove the epithelium, but alcohol and even a spatula can be used to do so. And nowadays, we use laser machines itself to remove the epithelium. The excimer laser is then applied to the bed for the number to be corrected, and after that is done, one may or may not choose to apply MMC. Depending on the amount of refractive error, the duration of MMC application is chosen, and then that is washed off thoroughly and a contact lens is applied to the surface. So the complications of this procedure, for the ease of understanding, have been divided according to the duration from surgical date. You get early complications, which are less than 6 weeks from the date of surgery, later complications, and of course, refractive complications that occur once you're out of the surgical healing process. So early complications, and one of the most important limitations of PRK is, of course, the post-operative pain and discomfort that we see, which usually peaks at around 24 hours after surgery. Majority of these patients experience significant discomfort, reporting a score of around 8 or 9 on a 10-point pain scale. This usually subsides within 24, 48, sometimes 72 hours after surgery once reepithelialization is complete. And it's usually attributed to the enhanced spontaneous activity of the injured nerve fibers. Various epithelial removal techniques have been devised to reduce pain. In PRK, the original technique was, of course, removing it mechanically. However, other techniques as shown in the video include the use of a rotating plastic brush or even the use of dilute alcohol on the surface of the epithelium. Alcohol traditionally has been found to have more pain than others on day one, and therefore many attempts were made to preserve epithelium. So LASIK was described early on, which then changed to epi-LASIK. And through history, a lot of procedures have been devised to retain that epithelium. The other thing that many surgeons have tried to reduce pain is to use chill BSS after ablation, because cold balanced salt solution is thought to provide analgesia by blocking the impulse conduction along the nerve fibers. A bandaged contact lens for 4 to 5 days to protect the de-epithelialized trauma and allow faster re-epithelialization can reduce the pain. And for pain management, you can combine the use of steroids with topical NSAIDs as well. Now, topical NSAIDs are often used to manage pain following corneal refractive surgery. And while there are many in the market, only around 0.1% topical diclofenac and 0.4 to 0.5% ketorolac have been FDA approved. And while they have some side effects like burning, stinging, and conjunctival hyperemia, they are known to be associated with more serious side effects such as punctate keratitis, corneal infiltrates, as well as corneal melts. So, although not extensively studied for post-PRK pain, oral NSAIDs including gabapentin, sumatriptan, and opiates are also excellent analgesics in many acute pain settings. So the other important complication and potentially devastating complication of PRK is a corneal infiltrate, which could be infective or sterile. This is sometimes attributed to the breakdown of the barrier function of the corneal epithelium and possibly the use of the BCL on an extended wear basis. In addition, we also use topical steroids post this surgery for a prolonged period of time, and that is also thought to possibly increase the risk of corneal infiltrates. So for guidelines on how to diagnose and treat corneal ulcers, this is a very useful management tool which is easily available on the AIOS website, the CME series, and this is an algorithm that I've picked out from there, which is easily accessible on the AIOS website. In contrast to infective infiltrates, this is what a sterile infiltrate looks like. These are seen outside the treatment zone with an intact epithelium and quiet anterior chamber. The contact lens is usually removed and sent for microbiology. And these sterile infiltrates are often peripheral and multiple, sometimes the overlying epithelium may be intact. They're usually an immune response to hypoxia or any other offending agent, and not seen very commonly. So thankfully, the overall incidence of infiltrates post LASIK and PRK is quite low and therefore not something to very seriously worry about. Though, of course, prevention is better than cure, and preoperative strategies like treating the ocular surface for dry eye, blepharitis, or any other risk factors helps to prevent this. It is never difficult to do certain things yourself. Like if you're not sure of certain things, you can drape the patient yourself, ensure that the lids are clean and sequestered, and treat aggressively at the first sign of infection. So the other important complication that we see is sometimes delayed epithelial healing. Epithelial healing post PRK is a complex process, and it can increase the risk of haze as well, which we will come to later. One a single article which I found on reducing or accelerating epithelial healing was on the use of autologous serum eye drops, which were found to be effective in accelerating epithelial healing. The other last thing which can sometimes confuse people if they are not used to seeing PRK in a high volume is the pseudodendrites, which are actually not to be confused with herpetic lesions, which are just seen and sometimes invade the visual axis because of epithelial healing itself. So later complications include the first one is a loss of best corrected visual acuity. This can be seen because of epithelial irregularity, central islands, and now not very commonly seen a decentered ablation. And of course, one later complication which we should keep in mind is ocular hypertension, and this is often attributed to the use of steroids. Steroids are a double-edged sword. We do use them after PRK surgery to reduce the risk of haze, but they can result in an elevated intraocular pressure, which can at times persist even if steroids are withdrawn. So the treatment is, of course, to stop the steroids, and in most patients, the IOP returns to normal within after cessation of this drop. So risk factors for IOP elevation are male patients, a higher central corneal thickness, low mean K readings, high myopes, and treatment with stronger steroids. Of course, the most dreaded complication that we see post PRK is a haze. Corneal wound healing is a complex process that culminates, of course, in restoration of the tissue. And what we want, most importantly, is no scar formation. The aim is to maintain transparency, to recover your vision completely. Haze is the end stage of a cascade of events secondary to stromal injury. And this is because surgery can result in disruption of the basement membrane, which eventually results in keratocyte activation, transformation to fibroblasts, which migrate centripetally to form myofibroblasts, which ultimately result in the scar that we see, which is haze. The risk factors are an increased depth of ablation, an increased diameter of ablation, high myopes, high hyperopes, if there is irregularity of the stromal surface in the post-operative period, and if there is very strong UV light exposure, which we see very often in our country. There are various grading systems to this haze. However, typically what we see is a transitory haze in the early post-operative period, and very rarely a late haze, which may persist in the post-operative months. And though this is less common, this is the one which is more difficult to treat because of the myofibroblast activation. So steroids, of course, delay the possibility of haze, but they are, as we said earlier, double-edged sword, which can result in delayed healing time as well. And it has been suggested that uh, the main cause of haze is the inflammatory reaction, which we see in the early post-operative period. And steroids, while they do decrease the inflammatory response, can result in an IOP elevation, as we spoke about earlier. NSAIDs have been used by some people to replace steroids. However, in our institute, the protocol has been to start steroids on the first post-operative day and do a slow taper of these steroids. Ectasia is a rare complication seen after LASIK and PRK and is not commonly seen post PRK surgery as it is seen post LASIK. And the treatment is very similar to post LASIK ectasia, where we serially follow up these patients, give them glasses and contact lenses, and if required, may need to cross-link them. Other refractive complications which are seen with PRK include over and under correction, very similar to that which is seen in LASIK. And high myopes are at a greater risk of overcorrection, especially older patients. And regression is something which is also sometimes seen, which is a myopic shift that occurs after a stable level of correction has been achieved. Undercorrection, on the other hand, is a residual myopia that may be present in the immediate or early postoperative period. So thank you so much for allowing me to speak. I hope that covered all the complications of refractive surgery, PRK surgery.
Thank you, Dr. Nicholson. It was a wonderful overview. Dr. Ruchaika, would you like to add anything to this?
Please
Yeah,
unmute
thank you.
yourself.
Please. Thank you, Dr. Rupal. Sorry. Regarding the ocular hypertension, how long are steroid drops are usually used? Because in my place, I encountered some of the young people very sensitive to steroid use. And maybe you have some other insight and what kind of steroid drops that usually you use at the clinic. Thank you.
Okay.
I might.
Yes.
I think Dr. Manak dealt with very nicely about haze. One aspect that we always do is to use mitomycin C, 0.02% for a period of 30 seconds, irrespective of the amount of refractive error that we are trying to correct. And I think that significantly plays a role. And also, she mentioned strong steroids do have a propensity for raising intraocular pressure in these younger individuals. So we usually use loteprednol, and you start about 6 to 8 times a day and gradually taper them down to about 4 times a day at the end of 6 weeks, and keep it on for about 3 to 3.5 months along with preservative-free lubricants. With these and limiting our refractive error correction to less than -6 diopters, we do find with the present day lasers, the incidence of laser is quite tolerable. You see it on the slit lamp, but hardly ever it's of a degree to bother the patient's vision.
Can I add a little more? So about the pain management, also giving a cold BCL and early startage of steroids does help in patients. Also, taking care that their vitamin D levels are really helping in preventing post-operative haze. So as something like cyclosporin eye drops, if necessary, preoperatively. So I think today it definitely has a role to play. Surface ablation stays as a good technique in our armamentarium. And if we know and handle these complications well, then they can actually give good results and can expand the indications for refractive surgery. It also helps in treating basement membrane dystrophy because the pseudomembrane that gets formed has a much better adhesion to the epithelial cells, and therefore you can prevent recurrent erosions. So surface ablation has to be learned today for anybody who wants to do refractive surgery. Anybody wants to add anything more?
Rupal, can I comment?
Sure, please.
I'll first comment that certainly in Australia, the shift has been towards transepithelial PRK.
Yes.
This is what a lot of centres are now doing as the standard. The other thing I'm observing is more and more people are using a bandage contact lens that's been soaked in a non-steroidal anti-inflammatory. And I just wonder if Dr. Malik could comment on that, whether she thinks that's a good idea.
Yes, Dr. Versace, we do that, not on a regular basis. There have been studies that say that dipping the contact lens on the NSAID or possibly using a cold contact lens is also helping in pain. Using the cold BSS or a cold contact lens helps in pain, and the NSAID also does help in pain, but with the advent of laser being used to remove the epithelium, we have seen the incidence of pain has gone much down, and patients are much more comfortable. Even just giving a topical NSAID for thrice a day for 3 days is helping. So that way, we're not dipping our lenses in NSAID anymore. But yes, we do dip our lenses in antibiotic, moxifloxacin, before we apply them. And we do wash the eye with cold BSS. That helps with pain.
So
Dr.
shall
Patrick,
we move on to the next one? Dr. Mars, are you ready?
Yes, I'm ready with the presentation.
Mars is going to talk about what have been additions which have helped us to give better quality and quantity of vision to our patients, and what are the limitations to those technology. And I'm sure you'll be able to clear all the doubts that the people have in their mind. Dr. Mars.
So, yeah, are you able to? One second, please.
Dr. Mars, please share your screen.
Yes. Are you able to hear me?
Yes.
Right. Share. Right.
We can see your screen.
Right. So a very happy Republic Day to all of you. And thank you, Dr. Rupal and AIOS, for giving me an opportunity here for presenting my talk, which is Refining LASIK Outcomes and Advances in Ablation Profiles and Topo-Guided Surgery. In topo-guided surgery, though we have a lot of options, we would be speaking about the Quantura by Alcon. So I have no financial interest in any of the products which I am going to mention. So conventional laser excimer profiles performed identical ablations in all patients with same refractive error. This resulted in induction of higher order aberrations on treatment. Wavefront optimized ablation profiles aimed to reduce the treatment-induced spherical aberrations. How they did this was by inducing a prolicity on the cornea by firing extra energy on the mid-periphery of the cornea, that is more than 30% than what conventional lasers did. This resulted in prevention or mostly nullification of induction higher order aberrations induced. Then now we have the topography assisted treatments which not only prevent in inducing abrasions, but also treat pre-existing abrasions present on the cornea. Now, what do you need for this? Basically, you need something to measure the abrasions and the topography preoperatively. Here in the Alcon system, we have the topolyzer, and then you need a software to transfer this from the topolyzer to the excimer laser. So you have a software, and then you need to have the excimer laser to analyze the data and to present the ablation profile. So this is how the Allegro topolyzer looks like, and this is EQ500 machine by Alcon. Now, what does the topolyzer do? Basically, it's a Placido disc-based topographer in which concentric white and dark rings are projected onto the cornea. The resulting image is analyzed, which detects the Meyer edges, the pupillary margins, and the location of the pupillary area centroid. And this calculates the height data for the areas measured, and the Meyer images are available. We use about 4 to 6 images to create a median height profile. Now, this profile of our cornea measured is subtracted from the nearest best fit sphere to give the irregular height profile. This aims at creating a perfect spherocylinder postoperatively so that the higher order aberrations can be minimized. So basically what happens is you take the topo map, you subtract it from the ideal topography, you create an ablation for the higher order aberrations, and then you add the refraction data to give you a final treatment. This was first studied by a trial done for the FDA, in which it was a multi-center trial done in the United States. This trial concluded that more than 99% of the eyes treated were within 1 diopter of the achieved refraction. But the limitation of this study was that it excluded data of eyes in which the topographic data of astigmatism was not corresponding to the manifest refraction. If it was 2 diopters or more, and if the variation was more than 5 degrees, those eyes were not included in the data. And if the refraction was less than 1.75 of astigmatism, and the difference was more than 10 degrees, these eyes were also excluded. So now you have a lot of modifications because in clinical settings, you do not have the manifest refraction and the topographic refraction always matching each other. These were introduced by a lot of studies. A few important ones are the ones which I am going to discuss here. As per Kanellopoulos et al., the topography modified refraction technique, the power and axis were taken from the topography and spherical equivalent changes were added to the spherical equivalent. A retrospective analysis in the Kanellopoulos data revealed that if the difference in the axis was less than 20 degrees between the manifest and the topographic cylinders, we had good outcomes. But if the difference was more than 20 degrees, there was higher chances of getting a retreatment done. Then you had the Lyra protocol. The Lyra protocol is basically the layer yoked reduction of astigmatism protocol. In this, they theorized that there is a link or a yoke between the higher order aberrations and astigmatism. So if you remove the higher order aberrations, the chances of astigmatic corrections are much more higher. So in this amount of cylinder obtained by the topography and the axis of the cylinder by the topography was fed in, and that resulted in better astigmatic corrections. Then you had the Forsythus analytical engine, which used analysis and planning which included anterior corneal astigmatism, posterior corneal astigmatism, lenticular astigmatism, and topographic irregularities. And that resulted in a better outcome. But if you compare studies in which the topography customized ablation treatment was compared with the wavefront optimized treatment, there are no studies which say that there is a statistically significant difference in the ratio of uncorrected distance visual acuity of 20/20 or better, which is the final achievement we want in refractive surgery. But yes, incidence of higher order aberrations are lesser in TCAT treatments. So, in which conditions would your topography linked treatment be better? Let us study it by an example. Here we had a patient who underwent a LASIK 2 years back and was not happy with his right eye vision. He complained of blurring of vision and halos. A topography done indicated that there was a decentration of ablation, and with a spherocylindrical combination, he was improving to 20/20 vision. So we did a topolizer test for him, and the topolizer data was transferred onto the laser machine. Now, if you see here, we have not entered any refraction for this patient. Even without entering any refraction, the ablation profile shows that we need to flatten the steeper areas and we need to steepen the flatter areas. Now, what refraction should be entered in such conditions? There are no set rules or algorithms, but we follow a few anecdotal evidences in which we enter about 50 microns, not more than 50, and we correct about 60 to 70% of the spherical equivalent. So in this condition, if we would have used those two rules, by correcting a -2 sphere, this is a kind of an ablation pattern which we were getting. So this is how we entered it and we did a treatment for this patient. This is how the treatment plan was, and this is the final outcome. This kind of outcomes would not be attained with a wavefront optimized treatment, but only by a customized topo-link treatment. You observe how well the cornea has been smoothened. So this was the final outcome of the patient. He recovered to 20/20 vision post-operatively and was happy with the treatment. To conclude my presentation, if you have patients with higher order aberrations, irregular astigmatisms, astigmatisms higher than 2 diopters and mixed powers, your topography linked treatment definitely gives you an edge over conventional laser treatments. Thank you for your kind and patient hearing.
Thank you, Dr. Mas. It was really wonderful. It also cleared a lot of points. You can now stop sharing your screen. Dr. Pooja, are you here? Dr.
Yes, ma'am, I'm here.
Yes. Pooja, what has been your experience with this technology?
Ma'am, the topo-guided treatments in our hands have worked quite well, but as Dr. Mas said, that yes, we do need some nomogram adjustment. So there are many softwares which help us do that, but at many a times we have to see our patient outcomes of 100 eyes on how the outcomes are, and based on that, we have to customize our nomograms. But otherwise, yes, the technology is quite promising.
Anybody else wants to add anything?
Dr. Mas was essentially talking about Contoura, which has been essentially there and quite accepted. But nowadays we are moving on to InnoWise and WaveLight Plus, where we are not only acquiring data from the corneal topography, but also using the sitemap to get information about the axial length, about the wavefront aberrations in the eye, the topographic picture, and combining all this data to using a ray tracing profile to correct the eye, not only for the corneal aberrations, but also for the refractive error. Is one of the best ways of doing the refraction also. And when you integrate the topographic data along with the wavefront aberrations and do a combined treatment, that seems to have even more promising results. Of course, these are still early days as far as this technology is concerned. I'm sure that in the days to come, we'll be hearing more about it. And maybe this is the next iteration of Contura. And as far as wavefront optimized treatment itself is concerned, the wavefront guided treatment is concerned, or topographic guided treatment is concerned, we more often use it for irregular corneas, for eyes with keratoconus, eyes with corneal abnormalities, scars, etc. And that again helps us to optimize the outcomes in these eyes.
Sir, I would like to add one more point to what you said. We've been using Wavelight Plus, which is the Innovice, for quite a long time now. There are few of the patients in our country where the pupil sizes don't match or the refractions don't match because of the accommodation. So those times, if you have a very high cylinder, I think Contura may work better in those cases. Otherwise, what you said is absolutely correct.
I have one more query. So since we spoke about Innovize and possibly customized, so
the organizing committee of
if
all.
we're looking at the total ocular wavefront and we're treating on that, is that not changing with different pupil sizes? So are we not overcorrecting? How are the results?
The results are quite good. So basically, what you said is also correct. With different pupil sizes, the refraction does change. So that's why what the company recommends is that you take the first measurement and it should be you have to measure the pupil of patient's refraction should be matching or within 0.75 sphere. However, if it doesn't match in the first reading, you make the patient wait for 20 minutes, let them relax because that will relax the accommodation and then take the measurements. But they do have a step where they measure the pupil size of the ideal pupil size of the patient, and based on that they measure it. So that's not a problem. But sometimes if the refractions don't match in the first reading, then you have to make the patients wait, let them relax, and then try to take a measurement.
And do we also do this?
But otherwise,
so thank you very
sorry?
much.
Are we also using hyperopic patients for this?
It doesn't allow hyperopic treatments, the Wavelight Plus, at this point of time.
Thank you for the wonderful discussion, but I think we'll have to move on. So I have the next speaker, Dr. Sinjab, who sent his recording to us because he couldn't be here. He's going to be talking about lenticular extraction procedures.
First of all, I would like to thank Hello, everybody. First of all, I would like to thank the organizing committee of All India Ophthalmology Congress and Dr. Rupal Shah for the kind invitation. My name is Mazen Sinjab, consultant ophthalmologist working in Dubai. I was asked to give a talk about the SMILE. So I'm going to share with you my humble experience, what I learned with SMILE. And I'm very sorry to share with you the 3 road rules, as you will see. The first one is do not show respect. The second one is be a coward. And the third one is break the rules. The first rule is do not show respect to the pupil. And this is unlike to what we do with the LASIK and the PRK when we consider the pupil and make the optical zone larger than the pupil. To understand why we should not go beyond the pupil in the SMILE, let us remember together the anatomy of the lenticule. The lenticule consists of 2 planes. The deeper one is the refractive cut, which determines the optical zone, which is 6.5 millimeter. And the more superficial cut is the cap cut with 8 millimeter in the standard settings. The second point, how easy is the dissection? We know that the easiness of the dissection depends on the power, the spot size, and the spaces between the spots. However, there are three other factors. The first factor is the cap thickness or the level of the dissection. The second factor is the diameter of the cap and the optical zone. The third factor is the wide to wide. Let us start with the cap thickness. As we know, the cap thickness can range between 100 and 160 in the CE mark regulations, while in the FDA approval, it is just 120. And we all know that the anterior third of the stroma has dense layers of the collagen fibers. So the more superficial you do the cut, the more difficult the dissection. The second factor is the diameter of the cap and the optical zone. We all know that the periphery of the cornea contains dense collagen fibers. And usually when we go with the standard settings of the lenticule extraction, the cap cut extends just beyond the mid-periphery of the cornea, but does not go into the periphery of the cornea, where the collagen fibers are very dense. However, if we exceed this and we decide to respect the pupil and make the cap cut and the optical zone larger than the standards, in this case, we are going to make the cut through the periphery of the cornea, where the collagen fibers are very dense, which makes the dissection very difficult. The third factor that may have the same effect is the wide to wide. When the wide to wide is in the average range, then the cap cut in the standard settings will be just exceeding the mid-periphery without going through the periphery of the cornea. But when the wide to wide is short, in this case, even the standard cap cut will go to the periphery. Now, as you will see in this case, I exceeded the standard settings of the lenticule cut, and I decided to make the optical zone and the cap cut very large in order to compensate for the large pupil size. And as you see, the two entrance incisions are very, very peripheral and very near to the limbus. And as you will see here in the video, you will see the difficulty in opening the incision itself. And remember, the more manipulations you do, the more scarring and invitation to the vessels to invade the area. And of course, you will cause irregular astigmatism. The second rule is be a coward. And this is my advice to everybody who is still in the learning curve. I know that all of you are very experts and you do only one incision, which is 3 millimeters. But for me, I do 2 incisions. Each one is 2.2 millimeters. And I always keep the other one as a backup, just in case, as we will see in this video. In this video, I started the dissection, but as you see, there was bleeding at the entrance incision. So I stopped and I decided not to dissect from here, but to use my left hand and use the other backup incision in order to do the dissection. So I'm doing the dissection now in the same way that I'm using in the right hand, I am doing now with the left hand. That's why keeping a backup incision is very important, especially for beginners. And with the weak cell, I'm just pressing on the incision in order to stop the bleeding. And now I'm doing the dissection as usual. I'm doing this very carefully in order not to distort the entrance incision and tear it. I'm now dissecting the lower level. Now, while I am dissecting, the lenticule folded inside. So in this case, I decided to use my two hands in order to complete the dissection. So I introduced one instrument in order to catch the lenticule and the dissector and the other incision in order to complete the dissection. The third rule is break the rules. In this video, I'll show you that at the end of the operation, I irrigate the interface with Redfort, of course, no financial interest. There are two reasons to irrigate with the Redfort. The first one is to be sure that no remnants, and the other one is to keep the Redfort inside, and this will speed up the recovery of the lenticule extraction, recovery of the vision, I mean, and from next day you will get the wow effect. And this is just after the operation on the street lamp view, but next day it will be crystal clear and you will get the wow effect. And this is very important for the beginners as well. So as take-home message, avoid superficial cuts, avoid large cut. Be aware of small white-to-white. Keep another entrance incision as a backup and irrigate with prednisolone. And before I say thank you very much, I would like to invite you all to the Academia, which is the first Sinjab Academy physical meeting in collaboration with the Emirates Society of Ophthalmology that will take place in Dubai on 17 to 19 April 2025. Thank you very much.
We have with us Dr. Osama, who has been the pioneer in smile technique. Dr. Osama, would you like to have any comments here? Dr. Osama Ibrahim?
Hello, yes. Sorry, I've been trying to on the other side on the computer. Yes, I like Dr. Mazen tips very much. They are useful mainly for the starting doctor. Actually, we have tried all ways of washing the interface, and we ended up that the best way is the least. We stopped doing any irrigation, even with BSS or something. We only do massaging to the surface, squeezing to whatever fluid is in the interface. And this gives us very quick recovery and very smooth post-operative vision as well.
You also had tried the lenticule and used it in other ways to make use of lenticules, if you would like to
Yes.
shed some lights on that.
Yes, we actually have many patients who are unilaterally aphakic because of many reasons, including refusal of IOL implantation. So we have a series of patients who are aphakic with high hyperopia. And what we do is we use fresh lenticules extracted during the same day for a myopic patient. And then we keep them with the proper orientation in a steroid antibiotic fluid. Then we bring the patient. We do smile for the difference in the refraction between the lenticule, the myopic lenticule. If there is any astigmatism or anything, we do it. And we do 3 openings instead of 1 incision in the smile procedure. We take off the lenticule, and then we implant the lenticule, the myopic lenticule, upside down, so that the convex surface will face upwards. The 3 incisions in the Bowman's layer will actually act as release incisions, so they will help the anterior surface of the cornea to become more convex. And then it's very simple. We don't need any sutures or anything. We have a follow-up now. Some of these patients more than 1 year, and we are preparing it for publication.
Thank you very much. For the want of time, I think we should move ahead, and I would request Dr. Patrick Versace for talking to us about places where we can't go on the cornea to remove the refractive error, and then what alternatives do we have? Dr. Patrick Versace.
Thank you very much. Can you hear me okay?
Nice and loud and clear.
And my slides are up?
Yes.
Perfect. Well, look, first of all, of course, thank you so much for the invitation. I appreciate it. It's great to be amongst you. I'm going to talk about phakic lens implants, specifically the Visian implantable Collamer lens. And even your opening comment, Rupal, was something you can do when you can't do laser. And I guess one of the messages I have here is that I use the implantable Collamer lens not just for patients who can't have laser, but in some situations as a preferred intervention, even for patients who maybe could have had laser. Let me see if I can advance. So to be clear, these are my opinions. This is not the official star line, so just take everything I say with a grain of salt. Maybe something is useful, maybe you think it's not okay because it's not official according to the company behind the lens. Clearly, implantable contact lens is a wonderful option for us as refractive surgeons. We can cover an enormous range of refractive error, including astigmatism, hyperopia, myopia, without being bothered about the cornea. So it opens up a lot of possibility. It also means anyone can do refractive surgery without having to buy a laser. The setup costs are very low, and the skills, implantable contact lens surgery is not difficult. It's really about decision making and making the right decisions. None of this is new. Now, the implantable contact lens concept predates laser vision correction. This is a Strampelli lens. This is from the early 1950s, and it worked. All kinds of complications. So this is an option for patients, and I present it to patients as an option which is equal and in many situations better than doing laser vision correction. So the first of my 3, maybe 4 takeaway messages. First, to grow the ICL practice for ourselves, we should present it as a better procedure, as a reversible procedure, and not as the last-ditch option because you can't have anything else done to your eyes. That's the first tip I'd make. Clearly, there are some cases where you're not going to do laser when you've got a cornea like this, or if the cornea is very flat and you've got a high myope. Well, you're not going to do laser, so the ICL is preferable. But I now have patients who come to me who say they've been told they can have laser, they're -4, they actually want the implantable Collamer lens because they get the idea of it being additive and reversible. There's a lot published now to show that in many situations, the implantable Collamer lens is actually better than laser. So in this review, they looked at higher myopes, and certainly in most situations, the implantable Collamer lens outperformed laser. The refractive outcomes were similar, but in terms of patient satisfaction and safety, the implantable lens was better. Comparing it with SMILE for mid-myopia, once again, the refractive outcomes, well, SMILE was slightly better, but certainly in terms of safety and patient satisfaction, the implantable Collamer lens came out ahead. So for most situations, you can say that the implantable lens is actually better than laser. The only situation where it may not be, I think, is when you've got a small refraction and you've got astigmatism, a small amount of astigmatism, simply because the implantable lens has a limited number of increments of astigmatism down low. The operation's well known to us. This is now taking 8 minutes to do. I know people are a lot faster. I'm a very careful, cautious surgeon. We do have to pay attention, of course. This is all about detail. It's having the lens that's the right size in the right patient. It's understanding any pre-existing problems, corneal coma. It's understanding astigmatism, getting the axis correct for the astigmatism, and considering the pupil size. They're all things to consider. Perhaps the biggest barrier we have to making this perfect is still sizing. And I'm not going to answer the question of sizing in this talk today. That's not the purpose of it, but just to say that's where we still struggle to get this perfect. And interestingly, it doesn't really matter how you measure the eye, you're still going to have some patients where the lens is the wrong size. And we'll have a look at some of the reasons for that. The orb scan, of course, was the gold standard, but now it's probably Pentacam to get a white to white. And then, of course, there are other newer techniques using UBM, MS39, other devices to try and measure the eye in more detail. But even with these, we still have patients where the lens may be too big. There are certainly some parameters we should be attentive to. First, we need an adequate anterior chamber. Now, 2.8 millimeters is really the number. So for myopes, 2.8 millimeters, and you can go less than that, but you've got to be really careful, and that's going against the guidelines. The angle, we're going to talk about some more, and then the clear lens rise. In a patient with a large amount of clear lens rise, you've just got to be a bit more careful about choosing the right size lens and be sure you've got enough space in the anterior chamber. One of the important points I wanted to make today in this talk, and something I've been more attentive to in the last few years, is to understand what change will occur to the anterior chamber angle once we implant the phakic lens. And basically, the anterior chamber angle is going to reduce by between 30 and 40% with lens implantation. So you can predict what your angle is going to be after implantable contact lens surgery and feel confident you're going to have an adequate angle. So it's now one of the parameters I look at when deciding whether or not a patient can have the implantable Collamer lens. In this paper, they showed the change in the angle with lens implant, but interestingly, there was no correlation between the intraocular pressure and the angle over this range of angles. But there will be a critical point below which the angle is just too narrow and you will get angle closure. So we have to be careful for this. I did mention earlier that despite careful measurement of the eye, we will still get some lenses that don't sit properly. We may seem to have a funny vault, excess vault, unpredicted vault. And part of the problem is that we don't really know where the foot plates of the lens sit in the sulcus. The incidence of ciliary cysts is really high. In this paper, they showed that more than 50% of people, when they looked at them, had ciliary body cysts. So if one of your lens foot plates is sitting on one of these cysts, you're going to have a funny vault, and the cysts can be very large. So we use Pentacam now as our go-to, moving across to MS39. But happily, the Pentacam is pretty well validated as a good way to measure the anterior chamber angle. It shows a good correlation with the Schaefer angle scoring system. So for me now, I look at the anterior chamber angle using Pentacam, and that becomes one of my parameters when I'm deciding whether it's safe or not to do a phakic lens implant in my patients. I look at the lens rise, but here's a case where you've got a relatively normal vault, but still a shallowed angle. And I'll make the point that you can have a completely normal vault, but still have a compromised anterior chamber because of the angle shallowing that occurs. So it's not just the vault that gives us the answers that we need to know. So my second point in this talk is to say we should be more attentive to what the pre-existing anterior chamber angle is to reduce the incidence of requiring intraocular plantable contact lens exchange because of sizing problems. So I look at the angle as one of my parameters, and perhaps it's something that needs to be incorporated in the future calculators to help us know what physical size lens to use. Happily, the sizing is relatively forgiving, and we can get away with lenses that are big and small without compromising the anterior chamber. There's no question that over time the vault changes, but most of that change occurs in the first 6 months. And that's the reason that I don't try and work out what the final vault's going to be at the time of surgery. I don't believe in having a second lens available at the time of surgery and looking and assessing and maybe changing the lens straight away, because that vault is going to change a lot over the first few days, weeks, and months. So what's the minimum and maximum vault that we can accept? Well, with a fenestrated lens, there's probably no minimum. You can probably get away with no vault and there'll be enough movement of aqueous to protect the lens. Or you might argue that because you know that peripherally in a myopic implantable lens, you're going to have contact, you should have a minimal amount of vault present or it's not safe. But maximum vault, yeah. And the only limit really to maximum vault is the anterior chamber safe or not. If the anterior chamber is safe and the angle's not compromised and the pupil's not distorted and you're not getting iris pigment chafing, then a large vault probably doesn't matter. But certainly once you get to 1,000 micrometers, you've got to think, is this vault okay? And of course, we have some tricks and tips to deal with excess vault. Now, if it's a non-toric lens and you've got too much vault, you can rotate that lens, rotate it to a vertical position, and you'll get a significant reduction in the vault. Sometimes repositioning the foot plates will help when you've got an unexpectedly large vault, because it may be one of the foot plates is caught up on one of those ciliary body cysts. And occasionally a laser iridotomy, even though you've got a fenestrated lens, may help to relieve a relative pupil block. I've never actually done that. So in summary, it's a big vault that matters really, and 1,000 micrometers is probably the cutoff, but it depends upon how safe the anterior chamber angle is. Now, my third tip, that's just a red tip with no discussion, is to say I no longer use cyclogel to dilate these patients for implantable Collamer lens, because these are younger patients. They get freaked out if they can't see up close. So you don't use cyclogel. Day one, they've got much better vision. They can see up close. My final and I think most important point for the talk is to say that viscoelastic is a problem. The incidence of pressure rises after surgery is high. At least 20% have a raised pressure within a few hours of implantable Collamer lens surgery, and a number of these will need to have a paracentesis to control the pressure. So I now try and avoid viscoelastic completely for the operation, like this. There's been a couple of publications to show this is safe to do, and this has been my standard now for at least 3 years, to do a phakic lens implant with no viscoelastic at all. You fold the lens using the normal technique, but just use BSS to make sure everything's really wet and lubricated. Don't use viscoelastic in the cartridge. Be careful, just advance the lens gently. It's a bit drier and will feel a little bit different, but I've never damaged the lens doing it. Just don't go fast or you're going to tear or rip a lens. Try and eliminate any air bubbles, of course, to make your surgery a bit easier. And when you come to the eye, of course, this is topical anesthetic. You make the main wound first whilst the anterior chamber is well formed and you've got a good pressure to push against. And it's just a slow and controlled movement. Once you've made the main wound, you move across, make your first side port through which you can manipulate the lens once you've implanted it. And there's still no viscoelastic, of course, in the eye. We're just working on the natural eye at present. And when you make the entry wound for your anterior chamber maintainer through which you insert BSS, angle it and make a long tunnel. You want your anterior chamber maintainer to be going through a long tunnel, so there's not too much metal exposed inside the anterior chamber, and you want it at an angle so that it's out of your way, and so the tip of that AC maintainer is not going to damage anything if it moves around. Similarly, don't take the anterior chamber maintainer down. Hold it with your hand, hold it with your fingers. You can use that if you've got a nice long tunnel to control the eye position. You can press against it when you're injecting the lens. You need to be using a single-handed injection technique. So this is a plunger injector rather than the screw injector, so that you've got control of the eye with your non-dominant hand. And again, it's just a slow injection. It feels very different because that lens can float around wherever it wants. So you do have to control the current of fluid going into the eye to get a predictable lens position. You can actually use the tip of the anterior chamber maintainer to help control the lens position. But your technique otherwise is the same. You tuck the haptics one by one under the iris, into the ciliary sulcus, and you align the lens for astigmatism. So by doing this technique with no viscoelastic, there are a number of benefits. First, of course, you no longer get a pressure rise after surgery. Surgery is actually faster, and patients get better vision on the first day, as shown in the couple of publications that are out there. We'll look at that in a moment before I finish up. It takes a little while to get used to it, but you can get good control of the lens. You can align the lens for astigmatism. The patients are comfortable, of course. This is no different for the patient with topical anesthetic. And of course, there's a cost saving because there's no viscoelastic involved. And once you're done, well, you simply remove the anterior chamber maintainer and the surgery is finished. There's no hunting for viscoelastic and no worrying about leaving remnant viscoelastic to give you a pressure rise after surgery. And we're done there. You don't need to use Diamox. I no longer do a pressure check, and I've not had a single patient with a high intraocular pressure with lens implant when using no viscoelastic. So to me, this is a good technique. And importantly, the endothelial health is the same. You don't get pressure, surgery time is shorter, faster visual recovery. In this paper, they showed that patients had significantly better vision the day after surgery, and the endothelial cell change was the same, if not slightly better, than what you get when you use viscoelastic. So thanks very much for your attention. Appreciate that, and I welcome any comments or questions.
Thank you very much, Dr. Patrick. It was wonderful technique and very good tips for everybody to adopt. Till Dr. Karitsan is sharing his screen, would you please stop sharing, Dr. Patrick?
Yes, I will.
I would ask Dr. Rolika if she has, what is the lowest that she's gone for ICL? The lowest that, Dr. Rolika, are you there? Dr. Karitsan, in the meanwhile, please start sharing your screen. Yes.
Ma'am, I've done a -2 rather.
Right. That's what I think the indication is going down and not just where we do not want to go on the cornea, as Dr. Patrick has rightly pointed out. So we'll go on to the next one. Dr. Karitsan, I'm sure you also come across a lot of patients who are already having dry eyes and they want desperately refractive surgery. So what do you do in those cases?
Right. Thank you so much, Dr. Rupa. Thank you, AIOS, for actually inviting me to be here. Now, I do have only 4 minutes, and I do not intend to actually go through a lot of literature on this. I think we have a research arm on doing the research on dry eye. There's a lot of data over here. But I want to share you with actually more in terms of how I actually look into this issue during our clinic. So there's a few issues with this when we look at our clinic, basically. Now, the first one, we will induce the dry eye. We are the one who actually the first inducer of dry eye after the LASIK surgery. We did better. We're doing better with SMILE, of course. But not all patients are the same. And if we look into this, not all patients will have the same response to the treatment given. Now, this gives us a problem because surely everybody has have the same experience in a busy clinic. We tend to have a standardized treatment. The reason why we do that because of actually the inventory that we have. And when we have multiple surgeons, again, the inventory will actually dictate the standardized treatment. So we look into this and we say that can we actually get whatever that we learn from the bench work, whatever that we learn from the research that we have into what can we do with our patient. I'll actually present 2 quick cases just to illustrate this. The first one is actually, this is a straightforward case where you have 37 years old female, a clerk coming with a very mild myopia coming to you. And then basically when you look into this particular patient, there's no cornea staining. There's actually speed test that we do in every patient. It's actually no dry eye syndrome at all. So when we look at the pre-operatively, so then, even though the patient, and this is actually the speed, we translate it into our own language, apologize for that. But what it says that the patient really do not have a symptoms at all. But when you look at the ocular surface analyzer that we have, and this is one of the way that we've tried to find a way to justify our procurement that we buy. So we do the ocular surface analyzer, but we actually find a lot of actually benefit of doing that. dynamically, we can see that if you look at over here, we can see that this patient actually have an issue with the tear film stability. But when you look up here, patient also have an issue of the lipid stability. But when you go down over here, we can see that, in terms of the meibomian gland up and down, and the lipid stability is better. But the tear meniscus is actually down, despite this patient doesn't actually have any complaint. So the question that we have with whatever that we have, what we will do with this patient, what we'll give. So we decided that because it's a tear film stability first, so we actually put a restorative agent. So 1 month after the operation, we go back and see the patient complain of actually dry eye now, as we understand that we induce that, and patient is not the vision is not that so pristine. We can see that this, when we look at the ocular surface analyzer, you can see that the tear stability become even worse despite the treatment that we gave with aqueous supplement. And when we look at that, again, it does not actually increase in terms of this patient's meniscus. Now, the good thing about having standardized questionnaire is actually for the patients to answer how many do you use after the op, only 2 times a day. Obviously, there is actually problem over there in communication. So when you look into this, and we use this to tell the patient, see, you begin with this, we worried about you having a dry eye, but when you actually come back 1 month, you even have a worse dry eye. You don't have an issue with your lipid layer because your tubularity is good. But when we look at this, now this is actually the appearance of a case. Now this dry eye, even though persistent, actually you have it before, it make it worse. Partly because you don't use the medication, we can document it now. And then the other thing is actually we start looking at, if you have inferior like this, you must have exposure keratopathy during sleep. So we start giving a gel and patients doing well. It actually gives us a idealized in terms of looking at the patient in the busy clinic, look at the point that we have. The second case is actually looking at into this as well. You have about moderate and high myop over here. You look at the patient is actually, OT nurse. Again, when we actually look at the cornea, we stain and everything before op, there's nothing there. And then we look at speak test, the patient again doesn't actually complain a lot of things. The only thing that the patient actually have is actually tiredness over here. So when we actually present to the patient again, when we look into this, we say that your tear film is actually a bit stable, because it's not that the tear film stability that you have a problem, but according to this data, you have this what we call the lipid layer issue. Now, when we show this patient that we already diagnosed them, you do have dry eyes that we usually miss if, let's say, we don't do ocular surface analyzer. We say that in this case, what we're going to do, we will actually give you lipid restorative agent, because we want to know that this is better. Then I think when we actually get it better, your term meniscus will be there because the volume is good. Now, when we look into this is actually 1 month post-op. Having this particular result is really good, because we can tell the patient that you're maintaining it very well. We have improved the lipid layer because we give you lipid restorative agent. It is actually worked very well. Now, that is actually the short thing. What we actually understand, what we cannot actually, avoid, that we will induce dry eye in the patient. Not all patients are the same. They're not actually have a same response. But in the busy clinic, individualized treatment and medication with inventory can be actually utilized well. And we found that the ocular surface analyzer is new armamentarium for us to look at the patient who actually dry eye. And of course, patient will have a stone dry eye. We're not going to do anything on that. Then I hope the 4 minutes that I share with you will actually share insight in terms of anecdotal experience that we have in our practice. Thank you so much for the time. Thank you for the attention.
Dr. Kerizan, thank you so much for a wonderful tip, as well as the thing to look for when you are actually treating these patients. Dr. Raghav, would you please share your screen?
Sure.
I'm sorry, we are running out of time, so we will have the discussion at the end if time permits. Dr. Raghav is going to talk about a complication which is unique to LASIK procedures, basically corneal refractive procedures only, and which is also treatable. So, Raghav.
So good morning, good afternoon, good evening. Thank you, Rupal ma'am and AIOS for this opportunity. I will be discussing different approaches and management of a post-LASIK epithelial ingrowth. So it's a tale of 3 eyes, and all 3 were managed differently. I would want, it could be a bit, someone could differ in their management protocol. Please, I would love to discuss. So I'll start firstly. So So basically, post-LASIK epithelial growth is an uncommon complication that may or may not warrant any treatment. But in case there is any change in refractive error, there is an irregular astigmatism, or if there is very early signs of flap melt, it has to be treated. So this is the first case. This is basically two cases in one. So basically, a man had undergone microkeratome LASIK in 2005. The power was very low, 1.5. But then he had a regression and he had to undergo an enhancement in 2021. And the patient came to us in 2022 with decrease in vision in the right eye more than the left eye. This is the image of the right eye and the image of the left eye. You can see these very prominent epithelial cell nests that go actually from 4 o'clock to almost 8 o'clock in the right eye, and the left from about 6 to 8. So in the right eye, as you can see, the vision was compromised. The vision was 6/9 partials with a induced cylinder. And the patient, of course, did have a regular astigmatism. It was getting corrected with glasses, but still the patient was uncomfortable. These are a bit more close-up images. If you see the right eye, you can see very flocculent epithelial nests in the right eye, and so in the left eye also. So the plan was in the right eye to actually lift the flap, clean the stroma and the cap, and then actually put a BCL. And in the left eye, we used a YAG capsulotomy, a YAG laser. So if I look at the right eye, this is the video of the right eye. So this was, of course, about a 7 to 8-year-old LASIK. So lifting the flap was not very difficult, being a microkeratome LASIK, though the patient had already undergone a retreatment. So flap was lifted up. This was the area. You can see the increased stickiness in the area of the ingrowth. You can see it's pretty sticky. And once the flap was, we can see that we're using a blunt spatula to actually just remove these cell nests. You can see the collection of the cell nests here. What is very important is that once you remove these cell nests, you also have to clean the flap, because this lens, the epithelial cells tend to be sticky and they tend to be recalcitrant if it is not cleaned properly. So we clean the flap bed as well as the flap. And after that, we are going to put the flap back and put some fibrin glue. You can see how well we are trying to clean the flap and the stroma. And after that, we put some glue and we put contact lens. So this is how the patient turned out at 1 day and at 7 days and at 2 months. You can see how those fronds have actually repleted, and the patient did get back to 6/6. This is the other eye. We used Nd:YAG laser. You can see we divided the ingrowth into 3 zones, zone 1, 2, and 3. And we used about 12 to 16 shots, and this was done in over 3 sittings, not in one single sitting, and 0.5 millijoules shot each. So you can see after the end of the first session, you can see this was the initial margin, but the cells start to deplete. Similarly, in the session 2 and session 3, you can see how light the cells have become. Though even the patient was already 6/6 in this eye, this did not progress, and the patient still has about a 4-year follow-up, and the patient is comfortable. So this is a traumatic case. This was a 47-year-old homemaker who had undergone a LASIK about 5 to 10 years back. She came to us with a vision of 636 and 624. In the right eye, you can see she had a very high cylinder. This was asymmetric. Asymmetric astigmatism. Patient was not comfortable, was not 6/6, even with glasses or with a contact lens. So the picture will speak for itself. So this was basically the patient. So you can see the patient had had a fingernail injury, and this was where the flap was kind of amputated. You can see the fingernail entered from here, and there was very thick fronds of epithelial cells that had gone inside. So this was, the patient came to us a month after the injury. You can see that the eye is also congested. So basically, this is the left eye. The left eye was congested, and the vision was 6/6 in the left eye. The right eye was the one that was the main issue. The vision had depleted, and there was also a lot of circumcorneal congestion, which had to be treated first. Unfortunately, the patient was not willing for a surgical intervention, though this warranted lifting the flap and actually removing all these cells. But for a month, these cells were actually stable. They were not increasing. So we went ahead and did a medical management. Only a fluoromethalone was used, TDS for a week, and then BD and OD. So this was tapered over 3 to 4 weeks, and an antibiotic and lubrication. So at the end of 2 months, we can see there was some regression of the cells from the center, but it had not entirely gone away, and they were actually stable for about 2-3 months. And 2 months follow-up, the patient was also stagnant, but the patient did not want a surgical intervention, though that was our procedure of choice, but ultimately the patient was lost to follow-up. Just to conclude, so this is how the ASOST was in all 3 cases. So this was the first case where we use the NDAG. So you can see this is the preoperative ASOST. You can see those hyper-refractive epithelial cells, and post-operatively they were actually, post the laser, they were actually disappeared. Similarly, in the case with the relift and debridement, you can see how big the frowns are, and they actually disappeared. And similarly, in the third case, there was no surgical intervention, but you can see these very thick epithelial cell nests. So of course, diagnosing and managing is very, very important, knowing when to intervene and when to stop. We also have had cases of epithelial ingrowth post a smile and silk. Those, as of now, we have not managed because they were not increasing, and they were mostly near the wound and did not require any treatment. Thank you.
Thank you, Raghav. It was really nice. Dr. Gitansha, please share your screen. Gitansha is going to be talking to us about suction loss in a smile or CLEX procedure. With more and more people getting into CLEX procedures, it's important to learn about complications that are likely. Dr. Raghav, we may go back and discuss yours later.
Sure, ma'am, sure.
Thank you, ma'am. Am I audible?
You are.
Thank you. So today I'll be dealing with managing suction loss in CLEX procedures. I have no financial disclosure. Now, for the purpose of ease of presentation, I'll essentially be dealing with examples on the VisuMax Smile platform. Having said that, it is important to note with the advent of the newer machines, which have a limbal suction with a higher vacuum, such as in the clear and the silk, the incidence of suction loss has reduced. Now, when we discuss regarding the management, when the posterior cut, which is the refractive cut, is more than 10% complete, one has to switch to a femtosecond LASIK. In all the other cases of suction loss, the treatment can be completed in the same sitting using the same PI, and the smile can be completed. When we're discussing suction loss during side cuts, be it either the lenticule or the main corneal access incision, one has to decrease the diameters of the cap or the lenticule in order to compensate for any subsequent errors in the docking and the centration. Now, this is a case of suction loss when more than half of the refractive cut has been completed because of a sudden movement. In the same sitting, the same PI can be used, and the procedure has to be converted into a femtosecond LASIK. This is an example of a suction loss during the anterior cut. You can see that the posterior cut will complete uneventfully. Now, this is the stage where this green blinking light, which is the fixation light, is obscured by the OBL, and it is important to caution the patient not to look for it. So because of these sudden movements that you've noticed and the posteriorly encroaching conjunctiva, the suction is lost and we have failed to complete the procedure. One can continue with the anterior cut. Now, since there is a plane of least resistance, there is an already formed cleavage plane, the femto cut will go at the same plane of the cap. The other advantage of docking immediately is also that these footprints of the PI, which were docked first, in the second dock, they will sit in the same position. However, the disadvantage would be that the dense OBL in the center would obscure the fixation of the patient, and the centration may be a little suboptimal, as you can see in this case. So one can wait for a little bit for the OBL to clear if one needs a proper fixation from the patient. The remaining procedure would be again a normal smile, wherein the anterior and the posterior planes are delineated and subsequently dissected, and the lenticule is removed. Now, very often there is a suction loss during the corneal side cut. However, even though the laser shows complete delivery, there are reasons that might result in an attenuation of the laser delivery, especially in the beginner surgeons where there might be a tear meniscus encroaching superiorly or a conjunctiva, wherein you have a side cut, but it's not quite complete. So we have published the use of an MVR blade to open these side cuts. However, this would be better in eyes wherein there is something that the surgeon can see which can be a guiding factor for the side cut to open. However, this was another case which was done in the initial learning curve where you can see that there is a posteriorly encroaching conjunctiva, but we continue to go ahead with the laser. And obviously the femtosecond laser delivery did not go through. However, the machine showed a complete femto delivery and we could not do just a side cut. The MVR blades do not work here because there is no semblance of a side cut which one can use as a guide. So what we did was we used the pattern D of the circle software as an off-label use and converted the initial cap into a flap akin the flex procedure. So one goes on to meticulously then delineate the cap along with the lenticule from the underlying stroma. It is important to make sure that there is no false passage creation at the junction cut. You can use a non-tooth forceps to hold on to the cap while the underlying lenticule is peeled off. It is important to make sure in these cases that the lenticule is removed in toto. You can see that there's a small sliver which was not removed, which is subsequently removed. The interface wash is done and the flap is reposited. However, when we do this and we use the pattern D software, one can say that the biomechanical advantage that SMILE offered is in a sense lost because we've created a flap. So what we did the next time around was the reverse, wherein we made a large inferior hinge. So this entire area became a hinge, and what we were left behind was with a very, very small side cut, which would resemble what a SMILE would give. So this was another case wherein we had a suction loss during the anterior cut, and there was no access to the lenticule. So we went ahead with the pattern D software and did it in reverse, wherein we made a very, very large hinge inferiorly and a small cut was formed anteriorly, which resembles what the original SMILE procedure was. The lenticule could then be delineated and subsequently removed without any complications, and all the patients got an unaided vision of 20/20 on postoperative day 1. So I'd just like to conclude by saying that it is important to guide the patient and to talk to them so they're calm and they don't look for the green light once it's gone to prevent suction loss. We can use the same patient interface in the same sitting. There are certain conditions wherein waiting for the OBL to clear slightly might be advantageous where you want the patient to fixate and look at the green blinking light. And the circle software can also be used as a rescue in certain cases in order to gain access to the lenticule. Thank you.
Thank you so much, Dr. Gitancha. It was really complete and it did throw a light on everything. Would you please stop sharing your screen? Dr. Osama, please share your screen. And I would like to ask Dr. Pooja, since you have experiences of so many platforms, do you think other platforms also have similar softwares to start and finish a procedure of suction loss? Dr. Pooja, are you there? Raghav, do you have any experience?
Ma'am, to answer your question, no, not
Dr.
yet.
Osama, please share your screen in the
Other
meantime.
Yes.
platforms don't.
Can you see it now?
Not yet, sir. Not yet.
Yeah.
So essentially, ma'am, I have experience with 3 of the 4 machines.
Okay.
In the clear software, as of now, there are no programs wherein you can continue from the point of last suction loss. However, the incidence of suction loss is very rare. We've
Yeah.
done around 2,000 cases. We've not had a single incidence of suction loss thus far. They do recommend an off-label use of the intrastromal pockets in case of
Right.
an anterior cut, wherein they make a cut which would be similar to the lenticule cut using their intrastromal pocket software. Silk and ATOS, the Schwint platform, both allow the machine to start from the last point of suction on and proceed, as is in the VisuMax.
Thank you so much.
Rupal, can I comment on that briefly?
Sure, please.
Yeah, I will say that one of the big differences is that with the VisuMax platform, you've got a plano anterior surface and then a refractive posterior surface. But with the other platforms, certainly with Schwind and with the Elita from Johnson & Johnson, both surfaces of the lenticule are refractive.
Exactly.
Even though with
That's what
Schwind,
my point was.
with Schwind, it's only 20%. So that means that really with any suction break, no matter when it happens, you theoretically cannot go ahead. Now, in practice, if you've only done a tiny amount on the posterior surface, you may redock and go ahead again. But it's going to be completely different because you've got a biconvex lenticule in both situations.
That's true. That was my concern too. But I think, as Dr. Gitansha pointed out, the incidences of suction losses are much less. So this problem doesn't arise. Dr. Osama, please.
Hello, good morning, good afternoon, good evening, everybody. Thank you for being here with us. And I learned a lot during the last 1.5 hours, and I hope we'll share together our experience in dealing with patient with high myopia and keratoconus. This is a 29-year-old female with bilateral keratoconus, more on the left side than on the right. Her uncorrected vision was only 3 meters. This was always thought to be an amblyopic eye, lazy eye. Her manifest reflection was -11, -5 astigmatism. Best corrected vision was only 0.1. With best rigid contact lens, the vision could reach up to 0.5, but however, she was contact lens intolerant. Our approach for such a case was to divide it into different steps. The first step actually was to do intracorneal ring segments with corneal cross-linking on the same city. We used the VisuMax platform to do the tunnels. We implant the rings. Usually we prefer to use unequal rings. The bigger one is usually down and temporal. It's not the case. This is a right eye of another patient, but it shows exactly how our technique is. We put a smaller ring, the upper, then we remove the epithelium in between, and we do cross-linking with the same conventional Dresden approach. We put it and wait until full saturation, and then we do the cross-linking. We followed up this, as you all know, the main advantage of the intracorneal rings is to regularize the cornea. It's not to stop the progression. The cross-linking will stop the progression. The intracorneal ring segments will regularize the cornea, as in this case. In our case, that's exactly what happened. This shows before, and this shows after the intracorneal ring segments. This is 1 year after the implantation of the intracorneal ring segments. Still, the patient has some significant astigmatism, but it's central and it's regular. So what's next? 1 year, the uncorrected vision improved to 0.1. Manifest refraction was still myope, -5, -5 at the same angle, same axis. Best corrected vision was 0.6, which is an added advantage. Since this eye is not truly amblyopic, we plan to go ahead and do SMILE for these patients. And since we are open, we will do an added cross-linking after 1 year. We call it SMILE Extra. This is the plan. The plan was, of course, to leave the same residual thickness, so we were unable to correct the whole myopia. We elected to correct the astigmatism and do the maximum myopic correction that we can. This is the procedure. It's important to have the lenticule in between the rings. The cap can extend beyond the rings, this is no problem, but the lenticule has to be in between the rings. We are lucky because usually we use large distance for the intracorneal ring segments. We use usually 6 to 6.5. We do the same dissection, but since this eye is cross-linked, we find that the dissection is a little bit difficult. Usually we use a
thin cap,
thin
the
cap, the
thinnest cap
thinnest cap
possible, which
possible,
is
which is
100,
100, and we insist of maintaining
the
the residual, safe residual stromal thickness. Once we take the
lenticule out, we
out,
inject
we
inject
intra
in the pocket
in the pocket a
saline-based
saline-based
riboflavin. We do it
riboflavin.
for three
Do it
times
for 3 times
with the 5 times in 3
5
minutes
times in
until
3
full
minutes until full
impregnation.
impregnation.
Then we do an
accelerated
epi on.
cross-linking epi on.
So we use either
So
a
we
3
use either
millimeter
a 3
continuous,
millimeter
a 3 minute
continuous,
continuous,
3
or
minute
6
continuous,
minute
or 6
interrupted
minute
with 10 seconds on and off. And we usually monitor these patients with the Corvus to see the effect on the corneal biomechanics. This is 3 months post-SMILE extra. The uncorrected vision improved a lot to 0.3. We still have -1 and -2 cylinder with which the patient can reach 0.8. If you can see this peninsula, this was of concern to us, but we noticed that all patients who had SMILE extra start with a peninsula of inferior steepening. However, with follow-up, this peninsula disappear, as you see here on the right side, the same patient after 6 months. So to sum up, this is our patient. It was a keratoconic, frank keratoconic with high myopia. We did ICRs to regularize the cornea. Still, the patient was left with some refractive error. We did SMILE extra, and the patient was really very happy. Still, we still have another option to continue if the patient is not very happy. We can add a topo-guided PRK if you have any residual refractive error. So we can use all our armamentarium to end up with a happy patient with the least possible refractive error. And it's more important, the best corrected visual acuity. Thank you all for
Dr.
listening.
Osama. This was the perfect use of technology and knowledge and experience to get the best outcome for the patient. Before I hand over to Professor Zhao for the final remarks, I would just like to thank each one of you to be here on a Sunday to be with us and giving and sharing your knowledge with such abundance. Thank you very much. Professor Zhao, please have the final
Yes.
concluding
Thank you, Professor Rupa Shah. You are not my old friend, but my teacher. I always remember the days 15 years ago I spent in your clinic in Baroda. It's wonderful days learn from you. Do participants do achievement remention? Do panelists and moderators? It's a true honor to have such a diverse group of dedicated professionals united by a shared goal towards true perfection in refractive surgery, advancing our knowledge and skills in refractive surgery. This session provides opportunities for all of us to share the expertise of our faculties. This session also offers a unique chance for us to exchanging ideas, share experience, and build cooperation relationship that cross borders, not from surface ablation, refine risk outcome topography guide, ablation, and the cracks. And every lecture, every speaker is very impressive. I learned a lot. And particularly Professor Versus, he presented a smile and ICL, and also I found the two topics, the two literature also written by my team, and I'm so great that smile, ICL, LASIK, PRK, and trans PRK, all of the kinds of the refractive surgery provides the unique quality for the patients. That's great. That's so great. Together, we can learn from each other, broadening our understanding of refractive practice. I hope our time here will be both enlightening and inspiring, and that we connections from will be lasting. Thank you, Professor Rupa, and all the speakers and chairman, and panelists are joining us, learning together. Such wonderful session. Thank you.
Thank you, and a happy Republic
you.
to all my Indian colleagues. Thank you very much. I think we can conclude our session here.
Thank you so
to
much for
AIOS for the
Thank you.
opportunity.
Ma'am, if we could have all the speakers put their cameras on so that we
Sure,
can have a
please,
group picture,
everybody.
that'd be great. It was a very enlightening, wonderful session that you all conducted. And thank you for your expert opinions and the videos that you showed. It clarified opinion issues for neophytes like me. So, can we all smile? Thank you.
Thank you.
So
Please
we
send
look
by
forward to the next
everyone.
session, which is MICS, the surgery for the world.
Thank you, everyone.
Rupa, thanks so much. Goodbye. Nice to meet you all and hope to see you soon.
Thank you.
so much.
Thank you, Dr. Rupa.
Please share that
Bye.
photograph with us, by the way.
Yes, please, Arshi. I'll do that.
Yes, sir, I'll just do that.